Welcome everyone. Thank you very much for attending on a fairly sunny evening on post-lockdown. I'm very glad that you haven't all gone to the beer garden and you have actually come to attend for my lecture. So thanks very much for coming. So I'm going to talk about educating for capability and sustainability of the healthcare workforce. So why do I say educating for capability? Well, this is a really good paper in the BMJ in 2001 where Tricia Greenhow and Sarah Fraser talked about the difference between competence and capability, and the fact that in order to deal with complexity, people need to have capability, and they talked about the difference between what competence is and capability. So if people are performing familiar tasks in familiar environments, then if people are competent, they can be able to do that. Whereas capability is when people can adapt to new environments and do things that they know what they're supposed to be doing, but do it in having to adapt to challenging circumstances, in challenging environments with new members of the team or things which they're not expecting. And that's when they have to deal. That's when they have to have capability to be able to deal with those more complex scenarios. And I mean, this is quite an old paper now. It's been published in 2001, but it's only until recently that the regulators and people involved in defining what outcomes-based education we're using have said that we should now be using bringing capabilities within our curriculum. And the GMC have stated guidelines and protocols that all Royal Colleges have got to base their outcomes within their curricula based on capabilities. And why did I include sustainability? Well, obviously, there is a lot of reports at the moment which are suggesting there's an impending workforce crisis. Fragile healthcare systems exist, and that's really been identified by the fact that we've got COVID pandemic at the moment, and has really illuminated policymakers and people involved in commissioning and running healthcare systems that these systems are more fragile than we actually really thought about before. There is an aging healthcare workforce, and we're also realising the fact that practitioners are at risk of depression and anxiety and stress and even burnout, and it's affecting retention of the healthcare workforce. We have got a lot of reports which are showing there's a dependence on internal migration, not of doctors and nurses and other healthcare practitioners. And there's a big widening participation in the gender one at the moment, because there's not just low numbers of healthcare workers in the NHS, for instance, and other healthcare systems, but there's also gaps in regional gaps around countries, and also regional gaps across different specialties. So where certain specialties and certain areas of countries are finding it difficult to recruit. And as a result of this, there's a lot of work to try to widen participation in medicine, as I'm sure a lot of you know, so that actually the healthcare workforce better represents the socio-demographic profile of the population it serves. And hopefully, if that's the case, and hopefully if we do widen participation in medicine and other healthcare programs, then we will have people in the workforce who will be more aligned to working in lots of different areas and not just more popular areas, and also across much more different specialties. So if we have a much more varied workforce, hopefully they'll work in much more, fill all the gaps that we have at the moment. Now we are promoting research in the development, recruitment and retention of healthcare practitioners through the CAMA research group. And CAMA stands for the Collaboration for the Advancement of Medical Education, Research and Assessment. And I've been leading this group for about the last 3 years, and we've done quite a lot of work funded for those programs. And I'll talk a bit about those in this talk. And it's good to see that that our research is also, it's aligned with the Peninsula Institute for Health research strategy. Future workforce is very much part of the knowledge mobilisation, part of that strategy, and we're really pleased that we're making a big contribution to that. So in terms of the workforce shortages, in my specialty, I'm an anaesthetist, consultant anaesthetist since 2005, so about 15, 16 years. And in my specialty, this report was published in 2015, which estimated that we need double the amount of anaesthetists by the year 2033. It's not just a problem in the UK. this report by the Association of American Medical Colleges also predicted a shortfall by the same year, 2033, of more than 50,000 anaesthetists in the US. But it's interesting that in the same publication, they mitigate against that risk by the fact that there are currently 58,000 certified registered nurse anaesthetists who will be able to help fill some of those gaps. But it's not just a problem with anaesthetists. Closing the Gap, this is a very recent publication by the Health Foundation, King's Fund and Nuffield Trust collaborating together, who have been looking at key areas for action on the healthcare workforce. And they've projected massive shortages, especially around nursing and general practice. And they've estimated that we're going to need at least 5,000 nurses to be recruited every year. And they're expecting that a lot of those nurses would need to be recruited internationally because we won't be providing enough of them through our own undergraduate and graduate nursing programs. So this is a recent statement by the King's Fund, only about a month ago. And it stated that the NHS workforce is in a crisis. And this has been really shown because of the COVID pandemic. And this is when they stated that 5,000 nurses are needed a year from overseas, actually. And it's not just a problem in nursing. And the Royal College of Anaesthetists have given a very bold statement again, very recently, saying that COVID has really emphasised the need for anaesthetists in practice and how important anaesthetists are. It's really stated the fact that anaesthetists are the people who are managing the sickest COVID-19 patients in hospitals, and they're critical to the restoration of normal surgical services. And they've estimated that more than 1 million patients will not receive their operations every year now due to the current anaesthetic workforce shortages. So something does need to happen. We've talked a bit about the dependence on international migration, and we've done some work. We've just recently finished a report for the General Medical Council on the drivers of international migration of doctors to and from the United Kingdom. Nicola Brennan, who is pictured here, is the principal investigator for this project. And what we wanted to do was understand the flow of doctors to and from the UK and then describe the migration push and pull factors. And we used a mixed methods design. We analysed secondary data which the GMC held. We analysed that to look at recent patterns of migration to and from the UK. And then we also did a systematic review of literature on the migration of doctors as well. And we classified countries into high, low, and middle income countries, and we've shown trends over the last 10 years of how doctors are migrating into the UK from these areas and into what specialties and what areas of the UK. This report hasn't been well, it has been. We've submitted it, but it hasn't been approved yet, so we can't really present much else to the findings at the moment. But this will be published shortly. And in terms of obviously, Brexit's going to make a difference as well, isn't it? So there's obviously political factors which are going to affect in-migration and out-migration of doctors. And it's interesting that the General Dental Council commissioned us recently to do a review and mapping of basic dental training in EU member states. Clearly, there's going to be some changes due to Brexit. And what we did is we looked at all of the countries in Europe, all the EU member states, and we looked at all of the graduate outcomes, whether there were standardised graduate outcomes in those countries, what they were, and how well aligned they were to the General Dental Council's graduate outcomes. And you can see in this diagram here in blue, we've got the UK, which is the benchmarking. And we compared all the graduate outcomes from these countries against the GDC publication, Preparing for Practice. And you can see that there's some countries here in red where they did have national outcomes, which is similar to the graduate outcomes for the GDC. There were some countries in blue, in light blue, where we weren't able to find those at all. And this involved surveys of regulators. It also involved website searches, and we did a very comprehensive, systematic search of literature, as well as website searches and surveys of regulators to get this information. So some information that we only were able to achieve was to find at a university level there were graduate outcomes, but not standardised across countries. And in some countries, in black there, we couldn't find any evidence of graduate outcomes at all. There's obviously a move in the UK at the moment to work towards licensing of medical practitioners. In the past, only international medical graduates from non-EU states would have to take the PLAB exam, which is a licensing exam, for them to be able to practice medicine in the UK. The General Medical Council are moving towards having what's called a medical licensing assessment, which is going to be taken by all medical students, whether they're trained in the UK or out of the UK. And as part of the work before the GMC decided to do this, they commissioned the CAMA research team to do a systematic research on the existence and evidence for national licensing examinations across countries comparable to the UK. And we did this in the CAMA. Tristan here, who is the first author on this study, did a video which is aligned to this paper, and it's really described very well the way in which we categorized the way in which countries use national licensing examinations based on candidacy, so based on the people who are taking those exams. We found, we searched evidence from 49 countries which were described by the United Nations as very high human development countries, and 23 of these did use national licensing examinations in some form. And we found that in class 1, this is where graduating medical students wishing to practice in their national jurisdiction must pass an NLE, national licensing examination. So basically, any medical student in that country would have to pass a licensing exam. Class 2 was all prospective doctors, whether they were within that country or IMGs. Class 3 were just IMGs, and 4 there was no national licensing exam in operation at all. So I suppose the UK at that time, when we did the study, was in class 3. It was only IMGs that needed to pass the exam. But we're going to class 2 in 24-25, the cohort of medical students who graduate in that year. All of those students will have to take the national licensing exam, which is the medical licensing assessment. So then we'll go to class 2. So I mean, I ended up doing medicine in the UK as an undergraduate, and then I ended up doing a lot of training in Australia. So I was part of class 3 initially when I was in the UK, but when I went over to Australia, I actually had to take their national licensing examination as an international medical graduate. Anyway, I thought I'd just talk a bit about my journey in education. So I went to school in St Joseph's Convent in Lincoln, and then we moved. My dad was in the RAF as an RAF pilot, flew Vulcans and got posted to St Morgan. We moved down to Cornwall, where I went to St Edward Primary School, and then ended up in a boarding school, Berkhamsted Boys School. Did a lot of swimming, played a lot of rugby, and then took a year off and went to Nottingham University. And when I went to Nottingham, I didn't really know what I wanted to do, so I chose my best A-level subject, which was physics. But during my year off, I did some community projects, both in Papua New Guinea. I was very lucky to get on an expedition over there, and also in the Pine Ridge Indian Reservation of South Dakota. And it's during that time when I was doing my community projects that I thought I definitely really want to do medicine. I've got the grades at A-level, and it's a lost opportunity. I really do want to do medicine. So I went to Nottingham, but I only had 2 main objectives in that year when I was doing physics. And one was to get into the rugby team. There were 4 rugby teams, university rugby teams. I got into the second team, so I was pretty happy with that. And the other thing was obviously to get into medicine. So I applied to UCAS and applied to change courses. And then just at the end of the rugby season, I got told I was in to do medicine. So I thought, that's fantastic. And left and went back home to Newquay, where I did a bit of lifeguarding on the beaches. So I thought lifeguarding was a good preparation for medicine. We had to do first aid on the beach. We had to look after patients. We had occasional involvement with the air ambulance, the occasional bit of CPR we had to do in the sand dunes now and again. And of course, it wasn't all that bad. We also got to get in the sea and do a bit of surfing as well. And it's got quite a good way of spending a summer and getting ready for medical school. It's interesting, actually, we got phoned up one day by a national newspaper, and they said, we want to do an article on what a great job lifeguards in Cornwall are doing on the beaches. And so we said, okay, that's fine. And they said, well, we're going to send a photographer down to take some photos of you, and we'll do a follow-up interview. So he came down, took some photos. And then later on, they did another phone call where a reporter asked us some questions. And asked the questions about if we were studying, where we're studying, what we're doing and things. And I was really intrigued as to how they're going to assess our capability as lifeguards on the beaches in Cornwall. Anyway, interestingly, this paper came out in the Daily Mirror about a month later. And it wasn't quite as we'd expected. This is obviously a journal which is well read, had a circulation of almost 4 million. This is probably the most read journal article I've ever been involved in. I was interested to see how they're going to assess capability of us, but unfortunately, the judges which they found for this particular article were not exactly experts in. Sorry, I've gone the wrong way. Not exactly experts in lifeguarding. So they asked four women, famous women, Linda Lusardi and Sunita and a couple of others, to markers and judges as lifeguards, but unfortunately they didn't really know what we're doing, didn't use any data on how many rescues we'd performed in that particular season or the success of those. They just used the article to mark us out of 10 for looks and to decide whether we have got a lot on top or are we just beach bums. And luckily they actually concluded that we did have some intelligence amongst us and that we weren't all beach bums, which was good. So then I went to med school, and this was my cohort. You can see we had a cohort of about 150, a very mixed bunch, and a lot of them have done lots of different things. It's interesting actually that about a third of them after graduation went over to either Australia or New Zealand within a couple of years of graduating. A lot of them came back to the UK just after a couple of years. Some have stayed over there, but it's interesting that this sort of migration of foundation doctors in between foundation and specialty training is not a new thing. It's something which we were doing, which was very prevalent even 20 years ago. I spent a lot of time doing anatomy. So this is my anatomy textbook here. It's well thumbed through. I spent about 4 hours a week studying anatomy. And it was something I really wanted to do well in because I hadn't done biology at A level. I'd done physics, maths, and chemistry. And I sort of overcompensated by studying really hard for anatomy and ended up getting top mark in the Viva after 2 years. We had 72 exams in 2 years, which seemed a lot, and it was a lot. And then we intercalated in our third year, and I got an opportunity to do a BMed Sci in epidemiology. Went back to Pine Ridge Indian Reservation and studied alcohol abuse in pregnancy. So I did an interesting study, which has ended up getting published in the South Dakota Journal of Medicine. So South Dakota Journal of Medicine, as I said in my interview, for my anaesthetic position at Royal Cornwall Hospital, it's a bit like the New England Journal of Medicine. It's just a different state. So then I did enjoy my med school at Nottingham very much. It was quite a traditional course. And then when I graduated, my first house job was in Exeter. I moved overseas to Gosford, as a lot of my cohort did, go over to Australia and New Zealand, spent 18 months there doing a residency program. All of my rotations in acute medicine, which gave me a good flavour for anaesthetics, which was really good for me. And then I got my first anaesthetic job in the Royal Cornwall Hospital, and then ended up getting on a training program at the Royal Melbourne Hospital, where I really enjoyed it. I was very lucky to have a supervisor called Kate Leslie, who was my research supervisor, and I got involved in some really interesting projects, and got some great opportunities for publications, which was fantastic. And even won at the ASA, the Australian Society of Anaesthetists Young Investigator Award 1 year, but I think there's only 2 people who applied. And I got a certificate for that, which is quite useful. And one of the projects we did is we wanted to see how many, whether there's a difference in the anaesthesia required for redheads compared to blackhead patients. And this was a multi-centre trial. It was well organised, and we basically tried to recruit as many people as we could to the study. And we had no problem recruiting dark-haired patients, but in an area of Melbourne where the predominant population is either Vietnamese, Italian, Greek, or Turkish, it's very difficult to recruit natural redheads to the study. So it was unfortunately we had to stop that early, and that was a bit of a shame. So that's sort of a very short history of my education and training to date, which, as you can see, was quite varied. I did really enjoy my training. I ended up in Plymouth at the University Hospitals Plymouth, where I became an anaesthetist. And I hadn't really done much in terms of education-based research, but I really got fully into simulation training. As an anaesthetist, non-technical skills is really important. At the time I became an anaesthetist, simulation was all the vogue, as well as assessment of non-technical skills. And so I, along with a lot of colleagues, really got embedded within simulation training within the trust across all clinical areas. We set up something called the Peninsula Simulation Network, and shared ideas and shared mannequins, shared resources across the whole peninsula. And I got involved in helped to set up the clinical skills and simulation training curriculum for the medical school at the same time as well. So I'm going to talk a bit about capability, how we educate for capability, and in three main things: recruitment and selection, education and training, and then retention. So the UK Med database was set up in 2015, and it's given us a great opportunity to understand the individual characteristics of doctors and how they're related to different training milestones in their careers. And UK Med was a collaboration of all of these agencies which held data on people who had started medical school from 2002 onwards. So you can see those agencies there. And so we've got continuous data which is all linked from undergraduates from before they even applied to medicine, how they did in their medical course, and then also how they did in their training through various measures which are taken for either from General Medical Council surveys or for when they apply for various specialties, their interview scores, etc., and also when they do their college exams. And so there's a very large longitudinal data set which we can now use or apply to use to do research. And I collaborated, you can see here, Paul Lamb and Martin Roberts, and we collaborated, and we've ended up doing about 3 different projects utilising the UK Med database. And one of those projects was we wanted to understand the factors which would predict whether people would apply to certain specialties. And at the time, general practice was a specialty which had severe workplace shortages and still has, as you can see from the reports I showed earlier. And also psychiatry is another sort of primary care type specialty, also had severe shortages, and anaesthetics too, which I've also highlighted. So we use this database to see what the individual educational factors were, which would predict whether people would choose to do certain specialties. So, so one of the sort of underlying research questions here was, who wants to be an anaesthetist? This is John Snow, who's founder father of anaesthesia. He was a white male working class background. His father was a labourer who worked on the coal yard on the River Ouse. John Snow was supremely gifted at maths, and at the age of 14 he started a medical apprenticeship. He then later on studied medicine at a university in London. He became a very famous epidemiologist, but then was intrigued by the science underpinning anaesthesia and became, as I said, one of the pioneers of anaesthetics. Probably by chance and not by choice. But I mean, I've talked a bit about the individual characteristics of this man who was a key figure in the development of anaesthetics. But what are the individual characteristics of the next generation of anaesthetists who want to do anaesthesia as a career, or general practice, or psychiatry? And do they represent the wider population? Or we can find that out through the UK Med database. So as I said, we've got data on before they went to medical school. You can see the sort of level of data here. So we know what gender or ethnicity these undergraduates are from, what their socioeconomic class are, if their parents had a degree, and if they had free school meals, what their A-level subjects were, and what grades they got, and also what scores they had in their aptitude tests when they applied to do medicine. We know whether they were graduates on entry to do medicine or undergraduates. And we know what type of school they went to. Did they go to a private school like me, or did they go to a state school like John Snow? And we also know what postcode they came from. So if they came from a postcode which was a high index multiple of deprivation, or a polar, and we also looked at polar quintiles, which gives us an idea of the percentage of the population in that area who normally go to a university. Then we got data on medical school, their age when they entered medical school, whether they intercalated because intercalation shows, often the people who are performing well in medical school get offered to do an intercalated degree, which is an additional degree during that program. And then we also know some of the features of their foundation program applications. So what their educational performance measure decile ranking was. So whether they were in the highest performing decile of the cohort or the lowest, for instance, and also what their score was for their foundation program application from the situational judgment test, which assesses professional dilemmas. And we, of course, we know which medical school they attended. And then there's postgraduate outcomes, how they did in their educational review every year, which specialties they chose to go into, and what interview scores they got, and also college exam results. So main aims of the study were to investigate the demographic and educational factors associated with junior doctors' decisions to make applications for the first time in these 3 specialties. And there were almost 8,000 doctors in that particular year that we took the data set who had applied to all specialties that we looked at. And of course, we used the UKMed database to do that. And we looked to see if they'd applied to these specialties alongside other specialties, or if they applied solely to these specialties. You can see that basically 70% of the doctors applied to just one specialty, whereas about 99% applied to 3 or less. And then this is the main results. And you can see in green, these are the factors. The factors are on the left-hand side, so the individual factors, and you can see related to different specialties. And in green, these are the factors which increase likelihood that they'd apply to those specialties, and in red, factors which would decrease likelihood of applying to those specialties. So in general practice, if these medical students were not foundation doctors at the time, if these foundation doctors were female from Black and minority ethnic groups, low socioeconomic class, from an area of higher deprivation, and from a state-funded school, they were much more likely to go into general practice. But with the measures of academic attainment that we had there, which was UCAT score, which is the admissions test to medical school, whether they intercalated or not, and whether their educational performance measure was below average, all these suggested they would be less likely to apply to general practice if they had high scores in those. Whereas in anaesthesia, if they were female and BME, they were less likely, and if they were higher age, they were less likely to apply to anaesthetics. If their parent had a degree, they were more likely, and if their educational performance measure was above average, again, they were more likely. And you can see in psychiatry, age had a sort of positive correlation. So if you're older, you're more likely to apply to psychiatry. And if you were white, if you're from a private school, again, you're more likely to apply to psychiatry, even state-funded school. And if you had an education performance measure above average, you were less likely to go with psychiatry. So we can get typologies now from this data to show exactly what sort of percentages of people would apply to certain specialties. And just as an example here, we've got if someone's from an IMD class 5, so an area of higher deprivation, who's Asian and have a very low UCAT score on admission to medical school, there's probably an 80% chance that they would apply to general practice. Whereas a white doctor from an area of least deprivation, so IMD1, with a very high UCAT score, that's on the x-axis, would have a percentage of about, I think that's less than 20%. So you can see massive differences just due to the individual characteristics of the people who are applying. Whereas in anaesthetics, there are different features which are significant, as I've already described, but these are the typologies which are quite interesting. So if you had a young white male doctor whose parents were degree educated, they'd have a probably about 13% chance of applying. This is out of all of the applicants to any specialty program. They would have a 13% chance of applying to anaesthesia, whereas older BME female doctors whose parents were not degree educated probably only had a 1 or 2% chance, 1 or 2% probability of applying to anaesthetics. We've published this in BMC Medicine a couple of years ago now, and there's a lot more data to be shown in this paper if anyone's interested. But I think it shows that there's obviously many factors that influence the probability that people will apply to certain specialties, but these factors are unique by each specialty. And they include individual personal characteristics, but also measures of academic attainment and educational factors. And the widening participation agenda is much more likely to help recruitment to general practice than anaesthesia at the moment, without measures to improve the attractiveness of anaesthesia or other specialties like that to more diverse groups. And this has been presented to Royal College of Anaesthetists, and they are working to try to do that, of course. So, you know, we need to try to improve the recruitment pool, and having data like this can give us an idea of just how we can try to improve the pool of people who want to apply to certain specialties or certain professional groups. But we also need to make sure that we select the right people, you know, appropriate people with the right skills and attributes who are going to succeed in those specialties or professions, and also, you know, be retained. So this was a systematic review of selection methods in medical education by Fiona Patterson and colleagues, published a couple of years ago in Medical Education. And they said there was an over-reliance on cross-sectional study designs and limited research on factors which look at the predictive validity of selection strategies. Now, I've been involved in doing a lot of work around developing and evaluating the national selection method for the Royal College of Anaesthetists. This is from about 2008 onwards. There have been a couple of job analysis studies amongst anaesthetists to look at the attributes which practicing anaesthetists felt training anaesthetists should have to be able to cope well with training and a career in anaesthesia. There were national person specifications drawn up for all specialties. And as a specialty in anaesthesia, we decided to base our selection method on non-technical skills, so attributes which assess capability for our specialty rather than competencies. And at the time, tools have been developed for the assessment of non-technical skills, primarily for use in simulation training. So we chose these particular attributes: situation awareness, organisation, etc. And then we had to choose particular stations that we would assess these attributes in. And you can see that we designed an assessment blueprint where we'd assess these attributes in more than one station. And we included work-related tasks such as presentation and simulation, along with more traditional stations such as an interview and a portfolio review. And we did some work evaluating the reliability. We found actually that we looked at data. Martin Roberts, senior psychometrician, did some very good analysis on the data, showed it was a very reliable method, had high reliability. We looked at content and face validity of the process, and we also looked at the predictive validity. So we followed up trainees who had been appointed through the selection centre format, and we assessed their non-technical skills in theatre within 12 months of appointment, and this was the ITA score. And we also looked at their scores from their educational review, which was an annual process. And we showed very strong correlations with their subsequent performance in the workplace within 12 months of appointment, showing that there was predictability of this method. Now, anaesthesia is, this person, Larsson, is a Swedish anaesthetist. He's published widely on the fact that anaesthesia is a high-pressure specialty. And there's an increasing amount of literature which identified that individuals who evaluate stressful situations as challenging rather than threatening may perform better under pressure and be more resilient to stress and burnout. And because of this, we wanted to look at how stressful our selection centre was. So we actually we asked the applicants when they went to our selection centre to rate on a scale of 1 to 6 how stressed they were going into the particular station. So how threatened they felt going into the station, but also how well they felt they were able to cope with the demands of that station. And this gave us something called a cognitive appraisal ratio. And so we looked at how people felt going into each individual station, and you can see that the scores were similar all over 1. So they felt fairly threatened by these stations, but more threatened by the presentation and simulation station than the more traditional stations. So the appraisal ratio was affected by the station type, but it was also affected by gender. So females felt more threatened than males on the whole. But gender wasn't an independent predictor of station performance. So the females didn't perform any worse overall, even though they felt a bit more threatened. But CAR between males and females was an independent predictor of station performance, showing that those who did feel threatened performed less well than those who felt they were able to cope with the demands of the situation. And this suggests that actually, if we're going to use a selection centre to assess our applicants on attributes relevant to high pressure specialties, it makes sense to have high pressure stations where where it does induce a threatened state, because it does seem to affect performance. And so it makes sense to that those people who perform well in a selection centre format would hopefully also perform well when under pressure in a clinical environment. We've done some work. We've collaborated with Marion Traynor in Queen's University in Belfast to also look at the use of the machine of the multiple mini interview for undergraduate nursing selection. And at the time, the Nursing Midwifery Council had published guidance on the values which nurses need to have. And we basically designed a selection centre, or an MMI, which is slightly different because they only have one rater per station, where we assess these values, which are all basically listed by the NMC in their national document, and we had different stations which assess those values. And again, we found fairly good reliability for the process. We didn't. The process was compared to normal interviews, and we showed that it did differentiate better than the traditional style interviews that were running at the time. So in terms of education and training for capability, like I said, I've been involved in simulation for quite a while, actually, ever since I've been a consultant. It's been a real passion of mine. And this article in 2014 by Jeff Norman stated that we need to abandon, this was an editorial in this journal, and it had about 5 different articles on simulation in the same journal, and Jeff Norman was the editor of the journal at the time. And he said that we should abandon requirement for authenticity at any cost, and actually use simulation, have simulation for all and not just a lucky few. And we need to distinguish between simulation-based medical education and simulation-augmented medical education. What he meant by that was that we shouldn't see SBME or simulation as a standalone event. We should integrate it into an overall curriculum, and it should be just one modality of education that we're using within that curriculum, and everyone should get it and not just a lucky few. Now, at the time, this was 2014, we'd been using simulation in the Plymouth Medical School for a long time, set up by Professor Bradley initially. I was involved and then took on the lead clinical skills role and worked very closely with the clinical skills team in John Bull and other centres around the southwest to have a standardised programme across the region, which was very comprehensive. And we had, each student would get 2 hours a week, 2 hours every fortnight of clinical skills training all the way through their course, and they'd have appropriate fidelity for the appropriate stage of training. And by fidelity, we mean the fidelity of simulator is the ability of a simulator to accurately mimic the cognitive and also motor elements of a criterion task. And so we don't just want to use a high fidelity simulator or a really expensive simulator just because we have it. We want to use appropriate simulation at appropriate times in the course for our students. And so, we used part task trainers a lot in the medical school, in Plymouth Medical School, so that our students could practice on putting in cannulas, doing arterial blood gases, performing IM injections before they would do it on real patients. And then later on in the course, we'd also they'll be using actors who are playing the role of patients to assess communication skills and learn communication skills. So these are the actors who are playing the role of patients. And then we used in sort of years 4 and 5 especially, we used team-based simulations where we're assessing teamwork, and of course, and we also use virtual environments as well. But I think the Plymouth Medical School is quite unique in the amount of simulation that it uses in terms of its clinical skills curriculum, and I think it has been shown in terms of the preparedness of practice of our graduates. Plymouth Medical School consistently performs either top or near the top every year of the surveys on preparedness of practice, which are done by foundation doctors and also foundation trainers. And I think the clinical skills curriculum is a main part of that, as well as a lot of the other programs that we use and focus on preparedness of practice within the course. So, and of course, there was virtual environments, and we did a study where we looked at the concept of distributed simulation in the Ebola pandemic and the Ebola outbreak in 2015. And distributed simulation has been defined by Roger Kneebone as a way of presenting real clinical settings in a lightweight, inexpensive, portable environment where we can provide just-in-time simulation to provide effective training and procedural skills to a dispersed workforce. And it seemed ideal to do it with the healthcare workers in Africa and West Africa who were struggling with Ebola. There was a lot of healthcare workers dying of Ebola at the time. And a lot of the resources which was being developed by the Centre for Disease Control in the US were written in English and given in English, and were not really understandable by the healthcare workforces in these countries. So what we did is we designed some modules which were initially given on laptops in the native language. This was in Liberia, and we also did it in Sierra Leone on laptops. And where we had people who looked like healthcare workers in their own environments, teaching them how to put on their PPE, personal protective equipment, how to take it off, and all of this is involved with working in these really high pressure environments. And we evaluated it. We showed that it improved their confidence in putting on and taking off PPE. We evaluated whether they were complying with protocols, and we also did audits in the clinical workplace as well to show the evaluation of this training. And we presented this and published it in the Simulation Healthcare Journal, and it also was awarded a prize at the AMI conference for Teaching Innovation Award, which is really good. So, I said we do a lot of simulation. This is what we used to use, a lot of team-based simulation, and still do. But at the time, it was uniprofessional, so we had a lot of fifth years all playing different roles. So you have a team leader, we have nurses, we have scribes. So, as I said, so we had uniprofessional simulation. So I collaborated with Ruth Endicott from Faculty of Nursing, and we had an opportunity to get some funding from the Higher Education Academy at the time, which we were successful at. And this was to develop interprofessional simulation. And so instead of having 6 final year medical students in these simulation scenarios, we increased the group size up to 12, but we only had half of them go in each scenario at a time, and half would look at a remote feed, so they'd be involved as observers, and then we'd swap the groups over. And you can see from this slide that obviously we had nurses and doctors in the same scenario, and it's much more authentic. So just by providing interprofessional simulation, it increased the fidelity of these simulated scenarios so much. And it's fantastic, but this was very joint collaborative effort amongst the faculty of nursing and medicine. And we had to, when we did the debriefing, which is probably much more complex in itself, we had joint faculty, so we had a member of the nursing faculty and a member of the medical faculty to do that. And Ruth and myself, as part of the study, we did a literature review on frameworks and quality measures which are used for debriefing, and we've published this. And we also had a preferred debriefing model, which we then implemented, and then we showed improved debrief quality as a result of that implementation, that model that we implemented. And we showed that the interprofessional working did improve team performance. So those people who went in the second scenario, the team-based scores were much better in the second scenario. So just having watched one scenario meant their team work improved in the second. And their attitudes towards interprofessional education also increased following each session, which is good. We've done some work with Becton Dickinson. I've collaborated with Becton Dickinson along with Rob Johnson, who's a senior clinical skills tutor in the Plymouth Medical School. And we developed some modules to train practitioners on how to perform intravenous cannulation, but we based it on capability rather than competence. We brought in the human factors module. This was all part of e-learning, but we mapped a lot of the content of this human factors module on a theoretical framework for patient safety, which is something called the SEEPS model, which is system engineering for improving patient safety. And it really focused the way that the practitioner or the person doing the task interacts with different elements of work system. So interacts with the technology and tools, the organization, the environment, and the actual task that the person's doing. And you can see we developed 4 modules. They've been translated into about 12 different languages, and BD have cascaded it around Europe, which is really good. And one of the things we also showed was the problem about the Swiss cheese model and how different barriers stop problems, and how in cannulation we gave some examples about how that could fall apart and produce an infection related to a cannula. And we had a master's student called Harry Carter, who we supervised along with Sally actually, and we did a qualitative evaluation of that training package, and found that actually students who'd done that training perform much better in a simulated task to perform a candidate in a challenging situation. And also we did some qualitative interviews, and they felt much better prepared to be able to perform cannulation in practice as a result of that modular training, which was online. So the UK, the GMC have brought in the medical licensing assessment, and we need to be cognizant of that as medical schools, and make sure that, you know, we're not only preparing our students for practice, but they're going to be able to pass the MLA. The MLA is going to be comprised of an applied knowledge test and also a CPSA, so a clinical problem solving assessment. And in our medical school, we assess clinical skills through something called an integrated structured clinical examination, which is like an OSCE, but is much more integrated. So it assesses more than one competency and actually assesses capability much better than an OSCE would do. And we also have been using the progress test, which assesses applied medical knowledge. We've been doing that ever since the beginning of the medical school here in Plymouth, where we assess how knowledge is gained even from year 1 up to year 5. And you can see here different cohorts of students. We've got a student here who starts in year 1, and these are mean scores. You can see this particular cohort started in, say, 1990. This started in 1991, 92, 93, 94. And you can see how through various years, of course, then medical scores of medical knowledge, applied medical knowledge improve. So they're all taking the same exam 4 times a year. So we're providing continuous assessment and rapid remediation, and getting away from those high stakes assessment that I had to take when I had to learn all this stuff at Nottingham Medical School, which is much better for the learner, and it means that they can identify their own learning needs. And I think the fact that we've been using the progress test for many years will hopefully prepare them well for the medical licensing assessment, which is going to be in place in future years. We've collaborated with some international partners through the EBMA, which is the European Board of Medical Assessors, to provide a study looking at online adapted progress testing. It's funded by Erasmus+, and these are the partners that we're working with, Exeter and also some Groningen in the Netherlands, and 2 universities in Poland, Helsinki and also Portugal. And what we're actually trying to do here is use progress testing, but make it much more individualized for the learner. And so if the learners are getting lots of questions wrong, they'll get easier questions. So there's an algorithm where if the student gets a question right, they'll get a harder question next time. If they get it wrong, they get an easier question. And the reliability and specificity of the assessment is much better as a result of this. And it's much more aligned to the learning needs of that student at that particular stage of the course. And it's a 3-year project. We're in 2nd year now, or almost in the 3rd year now, actually. We've evaluated, we've designed, over the 8 partners, we've written and tested 2,000 items, and we've got 1,400 items which are appropriate for use in the online adaptive part of the test, which is just about to start in May. So it's a really exciting project, and we'll be very pleased to give you more information about that once we have done the latter stages of it. So what is preparedness for practice? We've talked about this. What does it look like? Does it look like this? Or does it look more like this? There's been quite a lot of work funded by General Medical Council looking at what preparedness for practice is. And Lynn Monroe and Karen Mattick and colleagues did this particular study, it's about 3 or 4 years ago now, where they did some interviews with foundation doctors to look at how prepared they were for practice. And a follow-up study, the GMC they've highlighted some themes, and they've commissioned us to do a follow-up study where we're looking at 3 main themes of preparedness for practice. We're looking at a changing doctor-patient relationship, the multidisciplinary team, and also complex clinical judgment. And we're using a sort of mixed method study, looking at doing interviews with foundation doctors, interviews with foundation doctor trainers, doing a systematic search, but also using simulation to explore especially the multidisciplinary team and complex clinical judgment in crisis resource scenarios as well, to really understand how foundation doctors, this is amongst F1 and F2 doctors, are prepared for practice underlying these 3 main categories. And we're also lucky to be invited to take part in this study, which was led by Newcastle University, where at the time of the COVID pandemic 12 months ago, we had an opportunity to investigate the experiences of interim FIY1 doctors. And so we looked at their progress, we looked at the scope of work they were doing, and we also looked at their measures of stress and burnout during this transition period. We also did some qualitative interviews when they were F1s to reflect on all the experiences they gained during that interim FIY1 year. And there's no doubt that this particular experience for those people who did take part in it was very beneficial. This report has just been submitted to GMC for approval, so I can't really talk too much about the results at the moment, but this will be published and available for reading shortly. So in terms of postgraduate training, General Medical Council have recently published Excellence by Design. So this is the standards by which all postgraduate curricula must abide by now with their new curriculum, and all colleges have either written or are writing new curriculum to confirm with these standards, which need to include the values of a doctor from good medical practice, but also the generic professional capabilities, which I mentioned earlier. I've been involved in the Royal College of Anaesthetists new curriculum, especially around these defining and refining the assessment principles that we're employing within a new curriculum. And you can see that we're doing a lot of work at the moment to train the trainers in terms of what we're implementing. And one of the key features is that we're changing the work-based assessments to become not so much a tick box exercise, but to become much formative. So we're calling them supervised learning events. And this will include any cases which they are assessed on, and we're calling them, the cases are called ACEXs. They've got case-based discussions. They've got DOPS, which is direct observation for procedural skills. So we're making them all formative, and we're assessing them based on entrustment scales. So basically, we're asking trainers to assess for these particular tasks that the trainees are doing, how much supervision they would need if they were to perform that task in the same way with the same patient. Right, again, would they need the consultant in the room with them for the whole time? Would it be okay if a consultant went in the coffee room? Would the consultant be, would need to be in a hospital? Or would actually this trainee be trusted to do this case or procedure on their own while a consultant was available but on call at home? And it's by making these judgments explicit, we're having conversations with the trainees about judgments which we're probably making all the time. And then when I work as an anaesthetist, I'm always thinking about if I could trust a trainee to have a coffee break, or if I actually have some lunch or not. And it's decisions which people are making all the time, but by changing the scales from a 1 to 5 unsatisfactory up to excellent grading to something which is meaningful, hopefully it will encourage the trainers to have proper conversations with the trainees about why they're going to score them at a certain level for the supervision requirement they need for that particular case. And then we're also incorporating trustable professional activities, which is a sort of summative element of that. So SLEs will provide formative information about, for a lot of different cases and procedures, how much supervision they require. But the trustable professional activity will basically bring all that information together for all of those SLEs, plus also some consultant training reports and looking at clinical logbook to make summative decisions as to whether these trainees can be trusted to be on call for certain things like obstetric anesthesia, for instance, which is a critical progression point in their training. And we need to be sure that they can cope with that while at an on-call level before we let them on the on-call rota. A lot of this work is piloted actually in Australia. Jenny Weller and colleagues, who she's from New Zealand, did change the scale of their mini-CEX, which is the clinical evaluation exercise. They changed it from a numerical scale to an entrustment scale. They showed that by changing it, it improved reliability. They showed that trainees who were a higher year on the right, so the provisional fellow trainees in year 5, scored much more highly than the trainees in the early years. But they also showed that it did pick up about 3% of trainees who didn't perform at levels which were expected at that stage of training. So not only did it show performance, but it also did seem to pick up people who were not performing according to expected standards. And in terms of retention, so we've done quite a lot of work on remediation. It's important that we select the right people. It's important that we train the right people and we train with capability. But we also need to look after our doctors and healthcare practitioners You know, we might have people who need extra support or extra training, and we also need, and we've been doing a bit of work also on looking at fitness and practice procedures and looking how they work across different regulators and different professions for those who are obviously performing, having really serious performance issues. Restore is a study which is finished, and we've actually just published it in Medical Education. And it's looking, it was a realist synthesis on doctor remediation. Nicola Brennan, again, who I showed earlier, is the PI for this study. And we wanted to basically define what remediation was. Obviously, you know, doctors can perform at different levels, and other healthcare practitioners, and they fall below that threshold standard at a certain time when remediation is needed. But in the literature, you know, there's been commentators, Jane Clement, who's also a co-investigator in this study, said in this paper, we don't know what types of support work or how much extra teaching is critical, and we don't know precisely what works and why. And so what we wanted to do was to work out how and in what context and for whom remediation interventions work, and not just for trainees, but also for independent practitioners, so for people who are independent specialists. And yeah, we did this by doing a realist review. We looked at the literature. We had key stakeholders involved in it. We then developed a program theory for what works for whom and in what context. We checked it against key stakeholders at lots of different stages of the study, and we've come up with recommendations as to what does work for whom and in what context in terms of remediation. Certainly insight and motivation is really, really important, and conceptualizing remediation as a behavior change is also really important in anyone doing remediation programs. But obviously there's different things that work in different stages at trainee level or as independent practitioners. What we found is that the most of the literature actually was from the United States, not much from the NHS. And we've now put in an application to evaluate those interventions, those best practice interventions that we've identified in the NHS for another study called Restore 2, and we're hoping to receive news shortly about whether we've got funding for that, but we're very hopeful for that. So in terms of fitness to practice, this is a really nice study which Marie Bryce is the principal investigator for, and it's funded by the General Dental Council and Nursing Midwifery Council, and they wanted a research group to look at cross-regulatory seriousness across lots of different healthcare regulators. And the main aims were to develop an understanding of how the concept of seriousness is defined and applied across different regulators, to look at similarities, differences, and to describe the relationship between professional misconduct and the enforcement actions, so the sanctions which were applied. And we did this with a mixed method study design, and we, like I said, we did it across all 9 UK health regulators. We haven't finished it yet. We're using a thematic framework analysis where we're looking at all of the data which is available from these regulators. So case law, so legislation data, how legal decisions are made, what policies each regulator has and their guidance. And then we're actually looking at fitness to practice case files and looking to see how these regulators impose sanctions and what factors seem to affect those sanctions. And we're doing interviews with regulatory staff again across those regulators. And this is fascinating work. I'd like to show you more, and I'm sure that Marie will too when we can. And then we're also doing a study where we're working with the General Dental Council to unlock the potential of fitness to practice data for the General Dental Council. We've done some work previously in other studies with the General Dental Council, and we're basically building on that work. And what we're aiming to do is to understand and profile the fitness to practice related risk and related to dental professions, including complexity, and to basically refine the categorization and labeling of key issues within these cases. So providing recommending a refined coding framework for fitness to practice cases, so that they can enhance understanding of their decision making at all stages. And something else that GDC are really excuse me. Something else that GDC really want to know is how they can also move towards upstream regulation. So they feel that a lot of clinical practice cases could be dealt with more regionally. And from looking at this data, looking at the processes, hopefully we'll be able to provide some recommendations as to how they can do that. So now, in terms of clinical education-based research, the Newcastle University have just set up something called the NIHR Incubator for Clinical Education Research. And I think this is going to be interesting for anyone who's at this lecture who's interested in doing or is doing clinical education research. And the main aim of this incubator is a 3-year funded project from the NIHR. And its main aim is to increase capacity of the clin ed research workforce across all professions. So in other words, the whole aim is to support people to do research, fund them to do it, and make sure it's being done across multiple professions, but also to increase the visibility of that work as well. And they've got 4 work streams, which they're doing. And I was involved in work stream 1, which is scoping the definition of what clinical education research is. They're also developing awareness of the incubator, identifying professional differences, and looking to see what support is needed. But in terms of the scope and the definition, basically the definition is research which contributes to the health needs of society by enhancing the education, training and development of health and social care practitioners and the structures and contexts in which they work and learn. And so, a lot of the work which is funded by the NIHR currently is focused on research for patient benefit. And a lot of clinical education research doesn't necessarily show patient benefit straight away. But what we're trying to do with this work stream, scope and definition of clinical research, is to really emphasize the fact that if education research shows a tangible benefit to the workforce, then obviously it's going to have a direct benefit to patients. So with this the NIHR work, and if there's funding for this, for clinical research, if you can demonstrate that your research will provide a tangible benefit to the healthcare workforce, it's much more like it's likely to get funded if it's a well-designed project which advances new knowledge and has got good research methodology. So in summary, I think I've hopefully highlighted the fact that there is an impending workforce crisis for many different reasons. But we really need to focus our undergraduate efforts and postgraduate efforts on educating for capability rather than competence, so that they can cope with the increasing complex environment in the NHS. And we also need to have appropriate selection methods and initiatives to improve recruitment, so that we're improving people who have the capabilities to work in certain specialties and certain professions. And like I've highlighted earlier, we need to do more research to show what's working well, also what's needed and how we can best support our staff, best track people who are burning out, look at the indicators for those people who are not performing quite as well, and work with funders to evaluate best practice interventions and see how they do work in our workforce, and see that as a laboratory for trying to improve the way in which healthcare practitioners function. I'd like to thank everyone for listening. I'm sorry for the technical issues we had earlier. Thank you for listening, and I'd like to pass back to Sally to see if we've got any questions.
Tom, thank you very much. That was fantastic. And I know that if we were live in a lecture theatre, there would be rapturous applause now, and we'd be waiting for it to die down. So thank you very much and many congratulations. We have got some questions, Tom. We've got quite a few questions. The first question actually we got sent in before the presentation, and you may have answered it, so it may just be very quick. But you've been very successful in gaining funding for education-based research. And it's the question about how those involved in education research can get access to publicly available sources of research funding.
Yeah, I mean, that is a really good question. And as you said, I did touch a bit about this at the end with the NIHR Clinical Education Research Incubator. And I think that's a fantastic opportunity in itself. It's new, it's only been set up in the summer, so it's really new. They've got 3 years of funding. They're looking for researchers to get involved at the moment. So if you're involved in any profession in clinical education research, have a look at the website and join the group, because they're looking for active members to get involved. And I think, so getting involved in that is really important. But NIHR is only one funding stream, of course. I think we as a group in CAMRA have been very lucky that we've got an interdisciplinary team who have got a lot of experience in being able to and a good track record in funding, in getting funded research. And I think, but by working, collegially with other colleagues from other disciplines who've got methodological expertise in different areas. That's really important, isn't it? And I think, you know, building up teams within your own institutions across schools and looking for those funding opportunities is important. Of course, a lot of the time though, the funding opportunities come up with very short notice, and you have to be well prepared to be able to put these applications in within a very short time frame. And I think that's the hard thing. So, you know, the institutions need to help support people who have got the time to do that, because it takes a lot of time. And we need to have, you know, hopefully also repurpose applications that we put in previously for other studies and use those to try and bring in really strong proposals for the opportunities when they arise. So I think the forum is improving. I think, you know, the landscape will improve with all the work this NIHR incubator is doing. But I think as researchers ourselves, we have to work together to try and perform get as stronger applications in as we can.
Thanks, Tom. Thanks very much. So, Tom, there was a question that we've had this evening, which links very much to a question that was sent in earlier. So I'm going to just put those together, and it's about creating further healthcare partnerships and global classrooms, and how we can apply what you've been talking about globally, especially in low middle income countries.
Yeah, and that's really important. You know, I did some work in Sierra Leone, and I, you know, really enjoyed that project. I think Eddie Cole, who's the director of the Masanga Hospital, is actually is a member of the audience today. And you know, that the Ebola crisis really did show how fragile healthcare systems can be in these countries, and it's really important that we can help in any way we can through, you know, through funded research, but also through, you know, informal collaborations with these networks. I think if we're going to be successful with getting funding, large funded projects to be able to do this, you need to have really well established networks in the countries where you want to do the research. And I think the Global Health Collaborative, which exists in the faculty at the moment, is a fantastic you know, group of people across multiple disciplines who are doing that. They've got some very strong networks. There's researchers from Plymouth, but also Torbay, who are actively involved in funded projects at the moment. And I think we need to build up a reputation for doing that work. And you know, but I think the most important thing is establishing those strong networks in the countries where you want to do the research, providing appropriate methodological expertise by what I talked about before, you know, making sure we're working across disciplines to get the right people with the right skills for this research. But yes, and of course, we need to focus on capability, which is what we're talking about before, and a lot of the work you've done, Sally, as well. And you know, we need to think about healthcare professionals. Some of these countries that have difficulty retaining their healthcare professionals much worse than we have. I know in Sierra Leone they don't actually have licensing for their own medical practitioners to call them doctors, because actually the problem is they have real problems retaining them. So hardly any doctors that they actually provide there, and they have other healthcare professionals that they have doing a similar task. But I think we should be working with those programs, and that's a really exciting opportunity. I'd certainly like to do more of that.
Thank you very much, and leads quite nicely onto a question that's jumped to the top of the upvoting list, Tom, just now.
Oh, yeah.
First of all, it does congratulate you on your very well-deserved promotion and thanking you for an excellent presentation, and that is echoed across many of the comments. But it's about, do you think increased regulation from bodies such as the GMC in licensing new doctors through the MLA is a good idea or a bad one? Put you on the spot there.
Is this recorded?
It is. So I can move on to the next question, Tom, if you like. You just tell me.
I know it's recorded. So, I mean, this is a very good question. And I think, of course, the main reason that the GMC are doing this is to show that they are improving patient safety through the increased regulation of healthcare practitioners for all. And of course, their plans are to license, you know, UK graduates, EU graduates, and international medical graduates in the same way, effectively, so that the standards are the same. And you can see that, yeah, if you do that, the standards will be the same for all of those different groups of doctors. But of course, that may well have problems with migration. You know, one of the reports which I alluded to earlier is, you know, emphasising the fact that we need to have more recognition of appropriate qualifications from overseas. So actually, if you don't recognise appropriate qualifications overseas and you ask them to take a licence examination, then that sort of goes, it's counterintuitive, isn't it? It's not. So what some jurisdictions do is they will allow practitioners to work in certain regions or certain provinces on a temporary basis without taking a national licensing exam. So that's certainly the case in Canada. In Australia, where I worked, you can work in an area of need for a long time, or you can work in an area which is not an area of need for a short time without having to take that Australian Medical Council exam, which I took, by the way. And it's a right effort. I had to travel over to Australia twice, once to take the MCQ, then back to Truro doing my anaesthetics, and then back over again to the clinical in order to take the Australian Medical Council exam. So it is a real effort. I can understand the fact that this would put people off coming to our country or coming to other countries. So
we feel sorry for you, Tom, that you had to travel to Australia. Yeah, we're all sorry for you. We've got another question, if that's okay, which is liked by a number of people. Have you used, or do you know of any research into personality typing tests which assess capability or aptitude for medical specialties such as learning styles, Myers-Briggs, etc., either prospectively or retrospectively?
So that's a really good question. And so, you know, when we were looking at selection-based methods, going back to Fiona Patterson, she's done a very thorough evaluation on lots of different, you know, she's compared, you know, referees' reports with panel interviews, with psychometric tests, with multiple mini interviews in selection centres and everything else, and looked at the reliability, validity, etc., of all of those methods. Personally, I think that testing people on personality for certain, using psychometric tests like that would not be appropriate, certainly in anaesthetics. We don't want all anaesthetists to be the same type of personality, for instance. You know, we don't want a whole load of people like me. You know, it'd be a very boring department. So, you know, I think that on the whole, I don't really think, I don't buy into using those sorts of tests as a major selection method. I think, you know, I know in certain professions they do use psychometric tests for part of the selection process. We don't use it in medicine, certainly not in the, well, we might do in other areas that I'm not aware of, but we don't use it in anaesthesia or in other postgraduate specialties in the UK at the moment, and we certainly don't use it in undergraduate medicine. And I think, yeah, but you know, I think it sounds like the person who asked the question probably knows more about this subject than I do. So be good to have further conversation.
Brilliant, thank you very much. Probably time for a couple more questions, if that's okay, Tom. So the next question is about, it says, I was interested in your comments regarding WP in medicine. Why do you think it favours one specialty over another?
Okay, yeah, so, I mean, so widening participation, from the data that I showed, if we're going to have widening participation in medicine, I think the main aim is to provide people from diverse backgrounds in, such as from low socioeconomic classes, people who may end up living in index of multiple deprivation, who haven't had the same support in their own families and upbringing as the majority of people who come in to do medicine. And I think that's a great idea, and I think it will work, and it will work. And yeah, I think it's really important. I don't think that you know, undergraduates need to all get A-star AA to do medicine or dentistry, for instance, or whatever. You know, I didn't get A-star AA, I got A and 3 Bs. I think it wasn't too bad, but it wasn't A-star AA anyway. And you know, I really don't believe that our undergraduates need to be performing at that high level, but I can see why universities have tariffs that high, because they're in competition with each other, so there is high tariffs. So I do really support the notion of using widening participation to lower attainment levels that people need to get into do medicine, and from diverse groups. I think that's really important. It's fair to society. But you know, from the data I provided, well, we looked at more than almost 8,000 doctors who are applying in one round to lots of different specialties, And we found that those indexes of multiple deprivation, such as lower socioeconomic class, were much more prevalent in those applying to general practice than they were for anaesthesia. And we showed very significant effect, whereas those from an IMD class background, which was low socioeconomic class, etc., were much more likely to do GP, whereas they're much less likely to do anaesthetics. So that shows that at the moment, if nothing changes, anaesthesia doing something, you need to work on how they're going to attract people to their specialty from a wider group of people. And I think that's really important. Whereas obviously at the moment, general practice is quite broad. It's attracting people from a very wide array of people. And if there's more wide participation in medicine, they will benefit at the moment, whereas anaesthesia won't as much.
Thank you. There's a competition, Tom, now of the last 3 questions. So if we can get through them all quite quickly, that would be great. The first one is, do you see a role for continuing the interim FY1 into the future?
Okay, and that's a good question. And I do see a role of it. I think there's a lot of benefits from it. I think from my involvement in the project, their preparedness of practice on certain scales that we asked them to fill in was better for those who performed FIY1 compared to those who didn't. And the fact that they had done the interim FIY1 job in a very stressful environment, such as COVID, it didn't seem to affect their stress and burnout measures either, which is great. I think the fact that they were funded to do it, they were being paid as a proper member of the workforce, was very beneficial, and they like that. And so that's different to the assistantship, which is slightly different. I think a lot of medical schools use something like a 2-week assistantship before they do the foundation doctors, which is similar to an interim FIY1, but they're not actually paid for it. So it's slightly different. And I think that definitely made a difference. The students who, not students, are interim FIY1s, weren't they? So they're being paid, they felt like a proper member of the team. I think their experiences were different in certain places where they really felt supported in a way where they could make their own decisions, but also knew they had people to fall back on. That was very, very beneficial. But there were certain foundation doctors which probably didn't have quite as beneficial experience as well. So I think it also depends on the environment in which they're working. But on the whole, I think it's very supportive. And I think the GMC will be looking at doing something similar. I don't know if it won't be exactly the same, obviously, but they're certainly going to be considering how they can take this forward. And it'll be interesting to see what they decide to do and the further conversations they have with medical schools council, etc. I think it'll be interesting.
Yes, thank you. Okay. There's a question here about patient outcomes being hugely dependent on our healthcare delivery systems and not just on clinical capability. And redesigning pathways of care can be a great contributor. Do you incorporate systems learning into your simulation agenda? Yeah,
that's a very good point. And of course, we do, but in different ways. So I set up a master's in simulation patient safety, and this is not something that we do necessarily for all our undergraduates, but some of our undergraduates do it. Harry Carter, for instance, which I showed earlier, did a really great master's project which looked at systems engineering, so we do teach it. We teach it at master's level much more than at undergraduate level. We do teach on human factors, personal level and systems level in the clinical skills course. But there's not a lot of it on that. There's also some QI teaching in the programme. There's SSUs on quality improvement, so they get taught on quality improvement techniques and methods during their undergraduate training. But I think, we probably could do more, actually.
Thank you very much. Final question. This is going to be a tricky one, and you may want to pass on this question. And the question is, if I can even pronounce it properly, Tretheris or Treveglas? It matters.
I went to St Eville Primary School, and Tretheris, I lived right next to Tretheris, but I got sent off to a boarding school, which was Berkhamsted Boarding School. So I didn't go to either Treveglas or Tretheris. But yeah, good question. But I did love growing up in Newquay. I went to Cormorant Swimming Club. I played rugby for Newquay Hornets and lifeguarded at Hollywell Bay. And yeah, loved it.
Thank you, Tom. That's the end of the questions. Thank you very much. I am just going to now hand over to Professor Shubi Banerjee, Executive Dean of the Faculty of Health, to wrap up for us. Thank you, Shubi.
So, and thank you, Sally, and thank you, Tom, in particular. It's a delight to be able to take a couple of minutes just to say thank you to Tom for his fantastic lecture and for his fantastic work with us as well, which led to the fantastic promotion that has brought us to this talk today. And it's very impressive to see how well he coped with the technical faults that he had earlier, in a kind of with a calmness and authority that I absolutely didn't show when I was trying to log on and failed to do that before, which is, I suppose, why, Tom, you're an anaesthetist and I'm a psychiatrist, and probably that's the right way to go. So well done with that. I
was hoping you hadn't seen my technical difficulties.
No, the way you dealt with it was calm and authoritative, and that was absolutely the way to go. It was brilliant to hear of your life through medicine and research, and I suppose that beginning bit was characterized by this by a flight away from the Southwest in many ways. You kind of went off to boarding school, probably not your fault, probably not your choice, to Berkhamsted, certainly not your choice, I'm sure. But then back to Cornwall, and then you go out to Australia, and then you come back to the Southwest, and then it's off to the Badlands of Dakota, then it's back to the Badlands of Plymouth, and then it's off to Australia and come. That whole boomeranging thing is very good. It's obviously you picked that one up in Australia on your many flights over there to take exams, and of course that taking exams kind of characterizes a lot of what you've done. But I'm so glad you picked up that boomerang habit, because it's so brilliant, and we are so lucky to have you come back to us. I mean, to Tom, I mean, what you've demonstrated is just how you are fundamentally and absolutely at the forefront of research and practice in clinical skills and simulation and education. And essentially, that's all about quality and safety of care. I mean, fundamentally, what you do, Tom, and what Tom does for us is that he makes, good and safe doctors. And that is our fundamental issue. The work that you do absolutely serves that. And it's not just doctors. This is stuff that applies across all healthcare professionals. And it's absolutely brilliant to hear the work that you've been doing. And the fact that you do all of this kind of with one hand tied behind your back, because half the time you're an anaesthetist working in a really rather busy hospital doing lots and lots of work. And that's really important as well. And I suppose, the skills of an anaesthetist are not just about putting people to sleep. And I'm not going to make any cheap jokes at all about your putting people to sleep with this talk. You didn't. It was a really engaging talk. But it's also about waking people up, isn't it, being an anaesthetist? And I think that one of the things that I'm sure will stay with a lot of us is the fact that you legitimately, it was the best. I've seen a lot of inaugural talks, and this was the best and I think only legitimate use of semi-naked pictures of the individual giving the talk before. This is, I think that was a very brave and a very interesting thing to do. But one of the things it did make me wonder as I was looking at your head, and I was looking at your lovely suit jacket and your shirt and your tie, is whether you were wearing those Baywatch shorts underneath the desk as you speak to us. And it's one of the...
No, definitely not.
No, and I'll tell you what, we don't want to know. We don't want to see it, Tom. But look, what I'd really like to say is thank you, Tom. Thank you so much for working with us. Thank you so much for the talk. It's just fantastic having your wisdom and your care and your attention in the medical school. It's fantastic having it in the Faculty of Health as a resource. It's brilliant having it in the university, but it's also great having it in the whole of health and medicine, because what you're doing is of relevance absolutely outside of ourselves here in Plymouth, outside of anesthetics, to the whole thing. We're incredibly lucky to have you. So thank you, Tom. At this point, we would have worked up to thunderous applause for you. Now, I'm afraid we don't have lots of people to applaud you, but you just need to, as Sally was saying, imagine that, and I'll give you a clap. And I think that with that, we finish we finish the evening. I'll hand over to the events team, but here's a clap for you, Tom.
Thank you very much.